Hello, everybody. My name is Dr. Albert Heuer. I'm a faculty member at Rutgers University. I'm also an adjunct instructor in the respiratory care program at County College of Morris in New Jersey. I am the co-editor of several respiratory textbooks, including Egan's Fundamentals of Respiratory Care, and I'm the co-owner of A&T Lectures with Terrence Shenfield. And it is in this capacity that I'm coming to you today. In addition to being the co-owner, I'm also a presenter for A&T Lectures. And today, I'm going to be presenting to you on a topic related to understanding tracheostomy tubes and their care. In this session, we'll focus on several learning objectives. The first of these is we'll review the indications or reasons why tracheostomy tubes are put in place and maintained. We'll also examine the hazards of trach tubes. So like any therapeutic or diagnostic procedure, they have benefits. They also have hazards and potential complications. So we will try to present a balance of the advantages and indications as well as some of the downside. We'll discuss the insertion and insertion sites. We'll compare and contrast the types of trach tubes. In addition, we'll examine the trach and trach tube maintenance. So that would include maintaining the stoma, making sure that it's clean, making sure that it doesn't appear infected. If it does, that the patient gets the appropriate treatment to treat that infection, if you will. And the actual maintenance of the tube itself and the retaining device, the drain sponges that capture any leakage or mucus, etc., etc. Very, very important to keep that site clean and well maintained. We'll also broach the topic of facilitating speech in tracheostomized patients. Furthermore, we'll discuss weaning from trach tubes with the eventual goal of decannulation. And decannulation is a fancy term for the removal of the tracheostomy tube in a planned and controlled manner. We'll also review some case studies, and in addition, I'll provide you guys with additional references and resources for those who want to drill down more and learn more about this topic. There are several indications or reasons why tracheostomy tubes are put in place. One of them is to relieve upper airway obstruction. Now, we're not talking about the type of obstruction that's associated with asthma or COPD. We're talking about an obstruction that could be caused by some sort of a tracheal anomaly, such as a tumor, such as severe tracheal stenosis, or perhaps vocal cord issues or paralysis. In addition, another indication is the prevention of tracheal and upper airway damage due to prolonged intubation and mechanical ventilation. So what will often happen for patients who are on mechanical ventilation and have an endotracheal tube in place at about day 10 or 12 or so, the discussion will ensue. Gee, is this patient, can they be liberated in the next few days? Have they failed prior attempts? And if the prognosis for them coming off the ventilator at, again, day 10 or 12 is not imminent, it doesn't look like it's going to happen in the next 1 or 2 or 3 days, then the patient will probably likely be a candidate for a tracheostomy tube. Of course, unless the direction is going to be one in terms of palliative care and perhaps a one-way extubation with no reintubation. But assuming that's not the case, that tracheostomy should be done on or about 14 days or so after they've been placed on mechanical ventilation with little or no reasonable expectation that they're going to be extubated soon. In addition, tracheostomy tubes are put in place for easy or frequent access to lower airways in order to remove secretions via suctioning or coughlation. They're also put in place for airway protection So perhaps for patients who have had vocal cord paralysis, or they're in a persistent vegetative state and they have a Glasgow Coma scale that's extraordinarily low, generally less than around 8. There's a saying that if the Glasgow Coma scale is at 8 or less, intubate. Okay, so we're not talking about intubation here, but we're really saying that patients that have Glasgow Coma scales that are about 8 or less, they often have difficulty protecting their airways. And if it was for a prolonged period of time, that patient would be transitioned to a tracheostomy tube. In addition, and though it's an extreme measure, so extremely rare, it's an extreme measure as a treatment for obstructive sleep apnea, or OSA. So if a patient who has OSA has failed other modalities such as positive pressure, upper airway stimulation, and they have some concomitant severe comorbidities such as cardiovascular disease, high blood pressure, perhaps they have, they're a fragile diabetic that seemingly has been worsened by their obstructive sleep apnea, then they may actually be a candidate for a tracheostomy tube. So to be clear, one of the misconceptions is that folks that have untreated obstructive sleep apnea simply have daytime somnolence. There's many other comorbidities, including the ones I just mentioned. Diabetes or worsening of diabetes, cardiovascular problems, hypertension, and others that can be worsened by obstructive sleep apnea. So if the patient has those and they don't tolerate other treatments, this may be a way to address those things. So a tracheostomy tube, it is and can be a very effective way, although extreme, of treating obstructive sleep apnea. Some of the benefits of tracheostomy: decrease in ventilatory dead space. So the length of an endotracheal tube is roughly 3 times that of a tracheostomy tube. So therefore, the tracheostomy tube does a few things. Number one, it imposes about 1/3 of the dead space, so much less dead space. It also imposes much less resistance, thereby causing much less work of breathing. That is the work of breathing that would be associated with an artificial airway. Because it's much shorter, it would impose less resistance and better facilitate breathing, in particular spontaneous breathing, which is really what we want for our patients that have artificial airways and have mechanical ventilation. Less need for sedation, and the mindset with less need for sedation is the whole fact that they're more comfortable. That once the tube is in place and has been established, okay, that's the hard part. So there could be some pain, discomfort associated with that, some bleeding, etc. But once that stoma is established, the trach tube would better facilitate patient being able to eat, mouth care, them being able to speak, and just potentially being more comfortable than having an endotracheal tube in their mouth. It's also faster weaning, and the faster weaning really relates back to the first couple points that we made there, that the less dead space and less resistance that's imposed by the artificial airway. So if you took 1,000 patients with oral endotracheal tubes and 1,000 that had trach tubes, same size, let's say 8 and 8, you'd find that the ones that have trach tubes would tend to wean faster. Increase patient safety and mobility. So even though patients can accidentally get decannulated, the likelihood that the airway gets, that they get decannulated in an unplanned fashion is much lower than the patient's risk who has an endotracheal tube of having an unplanned extubation. So they tend to be much better tolerated, but also they're much more stable in terms of remaining intact and not subject to accidental removal. Also, ease of tube replacement for a mature tract. So once that the tracheostomy tube has been in place for a good month, that tract is nicely established. Maybe the tube's been changed once. From that point forward, future changes tend to be relatively straightforward. Also, ability to communicate. So the less need for sedation that I just mentioned, in the upper portion of this slide, really has to do with less need for sedation, greater patient comfort is about their ability to communicate, to eat, and things along those lines. Just as there's advantages and indications, there's also disadvantages and hazards. And some of those disadvantages and hazards relate to complications at the cuff site, including tracheal stenosis, particularly for cuffs that have been overinflated for a long period of time. They can impose that pressure on the delicate, if you will, tracheal wall, tracheal mucosa, and cause a reduction in blood flow to it, initially causing some softening, but eventually can cause some scarring to happen there. In addition, it requires specialized skill set, equipment, and personnel. So it's not something we do casually. It's something, particularly when patients are being converted, if you will, from an endotracheal tube to a tracheostomy tube. It's a process. It requires special skills and equipment. Stoma site bleeding and infection is another concern. Mucosal drying and thickening of the secretions is a further concern, because we know that the nose in particular is one of the mechanisms that not only allows us to smell, but it also filters and helps humidify the air that we breathe in. With a tracheostomy tube, that's bypassed. So you can have, much drier gas, particularly in the winter months, much drier gas going into the airway, and basically accounting for evaporation of the mucosal, the moisture in the mucosal wall, and thickening of secretion, things along those lines. Subsequent scarring at the stoma site itself. So it may be the actual stoma once the patient is decannulated, that they now have a depression there or a scar. Typically they can be surgically addressed to look normal or near normal, but it is certainly a cosmetic issue that's not insignificant. There's two common approaches to establishing a tracheostomy or placing a tracheostomy tube. Okay, one of them that's actually much more common than the other, accounts for well over 95% of the tracheostomies that are put in place, is just a surgical method, where it's either done in an OR or it's actually done at bedside in the ICU. Either an ear, nose, throat physician or an attending physician, a surgeon, will actually, be at the bedside or in the OR, and will make an incision, again, above the second, third, or fourth tracheal ring. Many of these patients have an endotracheal tube in place already, so there's great coordination between the physician doing the procedure and the respiratory therapist as far as managing the patient on the ventilator, but also in very gradually and on the request of the physician doing the procedure to gradually remove the endotracheal tube. And only remove it once end tidal has been confirmed through the tracheostomy tube. The other method is the percutaneous dilation, or just the percutaneous tracheostomy tube placement method. And what happens there is a small opening is made between the first and second, or between the second and third tracheal cartilage. And then there's catheters that are progressively larger that are put in that stoma in order to dilate it to the point whereby for an adult, a 6 or an 8 trach tube can be inserted in the patient. Much less common. So the percutaneous dilation method accounts for a few percent of the cases. And as I said earlier, the surgical method is by far the vast majority of the cases are done in that manner. This image is just to get away from the words for a minute and just to show you a little bit on when the method is done surgically, where it is, even some of the instrumentation that's actually done, the retractors that are there to actually expose the site so that the 7 layers of tissue can be gotten through appropriately. Any bleeding can be minimized. It's usually a cauterizing electric scalpel that's used, so it both cuts and cauterizes at the same time. And you can just see kind of that, if you will, front to back shot that's on the left-hand side, as well as the right-hand side that's showing you the lateral depiction of once the tube is actually in place, where it's located both on the outside as well as in the trachea itself. There's a lot of features and, if you will, design elements for tracheostomy tubes. So commonly used adult trach tubes, some of the features include the following. Many of them, probably over 90% of them, have a disposable inner cannula. Many of them are cuffed, air-filled. With a cuffed one, you don't have to use the cuff. You can deflate it, okay? And you can use it in a similar manner to an uncuffed one. Once you have an uncuffed in place, if the patient requires mechanical ventilation, that trach tube needs to come out and they would need to have a cuff tube put in. Non-fenestrated, so I'll talk more about fenestrations, but in some, a fenestration is just an opening in the bend, in the outer portion of the bend of the tube. The primary motivation for a fenestration is to facilitate talking or phonation. But many of them do not have fenestrations, just to be clear on that. And for adults, the most common size would be an 8. Next most common size would be a 6. But many adult tubes that are initially established are a number 8 interior diameter. Some of the other variations that you'll see in tracheostomy tubes, again, the fenestration. It's an opening in the outer cannula, and again, often the inner cannula, but mainly the outer cannula to facilitate speaking and spontaneous breathing. Non-disposable inner cannulas, also you can occasionally see them as well. And one of the ensuing slides later in this presentation, I will show you what a inner cannula cleaning kit looks like, the elements of it. Pretty much, they're pretty universal, to be honest with you. But those non-disposable inner cannulas do require regular cleaning in order to minimize any sort of plugging or any sort of infection risk. Foam or sterile water filled, you can also see them. So many of us have this assertion, if it's cuffed, that cuff is filled with air. It often is, but not 100% of the time. So you can have, Bavona makes, they also make air filled, but they make foam and sterile water filled. One of the indications would be if a patient with a tracheostomy tube, particularly one who's on mechanical ventilation, is going for hyperbaric therapy, what would happen is as that patient is brought down to 3, 4, 5 atmospheres, the barometric pressure at 3 atmospheres is 3 times what it is at sea level. So what happens is the pressure that's being exerted on that cuff will be greater. The cuff will tend to want to collapse, and there'll be more, if you will, air or tidal volume that will be escaping. So one of the guards against that is using a sterile water filled or a foam cuff. There's other reasons as well why they're used. Extra long trach tubes, so they can be extra long, if you will, front to back, or they can be extra long up and down. Okay, and it really depends on the patient's anatomy. If you have a patient who's had their tracheostomy tube for a long period of time and they're developing tracheomalacia, they may be a good candidate to have an extra long, if you will, specialized tube that's put in place. Cuffless. So I alluded to this, over 90% of the tubes have cuffs, but there's, some, particularly in a skilled nursing facility or even some LTACs, long-term, acute care facilities, where you'll see a greater prevalence of cuffless. In a home care environment, you'll see a greater prevalence of cuffless tubes. And again, mainly, exclusively actually for spontaneously breathing patients. Tight to shaft. I will show you an image later in this presentation on tight to shaft. So basically a tight to shaft cuff tube looks almost like an uncuffed tube. That cuff is made out of a silicone material that is, when it's deflated, it just adheres. There's no wrinkles in the cuff. It adheres to the outside of that trach, and it looks almost like it doesn't even have a cuff. The idea there is some folks that have very narrow stomas. You have less risk of the wrinkles, if you will, or folds in the cuff interfering with a cuff tube change. So individuals that have had problems in the past, they may be switched over to a tight shaft to better facilitate the insertion and the changing for tracheostomy tubes. And then you have the old Jackson metal tubes. And the Jackson metal tubes, they were at one time made of silver. Just for a whole lot of reasons, scarcity of silver, the cost of silver, things along those lines. They switched over to stainless steel, surgical grade stainless steel. But just bear in mind that folks that had Jackson tubes that were silver, silver is bacteriostatic. So that silver wasn't used to say, for bragging rights or anything along those lines. It was used for a very practical reason that, silver will tend to discourage microbial growth. You won't see many of those, but they're out there. This figure or image actually depicts the parts, if you will, of the tracheostomy tubes. So you actually have, the retaining ties or strings. You have the pilot balloon and the pilot balloon tubing. You have a outer cannula that has a cuff that can be filled again through the pilot balloon. And then you actually have the inner cannula, and near the bottom there, bottom center, you actually have what's called the obturator. The obturator has kind of a blunted end that protrudes through the end of the tube to better facilitate the insertion and to minimize any trauma or eliminate any trauma from the insertion. And then on the lower right hand portion of this picture, it's actually showing you a little bit more regarding the actual, instead of a line image, the actual tubes themselves, and showing you, for example, one that's fenestrated and where that fenestration is actually located. Looking further at images, the left-hand image there is a tube with a disposable inner cannula. The middle one there is showing you a cuff tube with a reusable inner cannula, and then all the way on the right with a disposable inner cannula. And again, just giving you a little bit of variations that are out there. This further demonstrates some of the options that are out there. The middle image here is actually showing you the fenestration, and it's a good depiction because it's clearly showing you where that opening is in the outer portion of the bend there. This particular fenestrated tube is cuffed, so in order to take full advantage of that fenestration, you'd need to deflate the cuff, or it'd be best to deflate the cuff. All the way on the right-hand side there, you actually have fenestrated, but it's cuffless. It's cuffless. So you can see the variety, the number and variety of tracheostomy tubes are very, very extensive. So many clinicians who are relatively new to trach tubes, in particular respiratory therapists and nurses, the initials, so for Shiley, they account for probably about 80% of the trach tubes that are sold out there. So there's many more initials than what I've depicted here, but these are the most common ones, okay? Particularly near the top. The DCT stands for cuffed with disposable inner cannula. I'm not going to read all these to you, but CCFN is cuffless with disposable inner cannula. CFEN, so you kind of that one certainly suggests that it's cuffed and it's fenestrated. The FEN being associated with being fenestrated, and then the other ones that are listed here, and still others that aren't listed here but are much less common. Another manufacturer is Bavona. Some folks think that when we talk about Bavona, they make only foam-filled cuffs. That's not true. They have ones that can be filled with fluid, in particular sterile water. They have air-filled ones and foam ones as well. Another variety of trach tube that's out there is what's called a TTS, or tight to shaft. Really what they're talking about is that the cuff is tight to shaft. And if you just take a look at this image for a moment and look at the distal end, okay, look at the end that's closest to the top portion of this slide. It almost looks like it's uncuffed, but what that really is showing you is that the uninflated cuff is made of a material that allows that cuff not to fold over in folds, but to actually adhere tightly to the shaft. It's made out of different silicone material. And again, it's designed really for individuals that are tough trach changes. In some other way may have some anatomic abnormality and can help better facilitate changes in maintenance. Now let's turn our sights for a moment to care and maintenance. So many facets to it, but including things like suture removals. So for new trachs, can be done as soon as about 48 hours afterwards. So you have flange sutures, and depending upon the protocol at the hospital, as soon as 24 to 48 hours and as long as about a week. And it depends on a lot of variables and really driven mostly by the patient and the clinician who's done the actual procedure. Cleaning around the flange, very important. There's kits available for doing that. There's also hospitals that use mouth care kits with the sponges in order to keep that site as clean as possible. Generally done at least every 8 hours. Intercannula changes, depending upon the hospital, every 2 to 3 times a day or sooner if warranted. So every 8 to 12 hours. Intercannula cleaning. Again, that would be done at a similar interval, but that would be for obviously non-disposable intercannulas. Cuff pressure checks at least every 8 hours. And that would be done for mechanically ventilated patients or spontaneous breathers. When to deflate the cuff, so really important to remember and to just remind your staff that if the patient's spontaneously breathing, the cuff should generally be deflated. There are rare exceptions. At the acute care facility where I work, we have an active head and neck cancer program. And what happens is for individuals that have had, let's say, a neck resection because of a malignancy or other condition, we typically will keep the cuff inflated despite the patient being spontaneously breathing. For the first day or so after they've had the surgery, they may elect to keep the cuff inflated to help reduce the amount of drainage that goes down into the airway and potentially into the lungs. But by and large, spontaneous breathers who have trach tubes that are cuffed, the cuff should be deflated. Speaking valves, we'll talk a little more about them. Changing tubes about every month, sometimes more frequently, depending upon, again, the particular clinical circumstance and patient. This figure or image is just really to depict the fact that there are these commercially available intercannula cleaning kits that are out there. And, then they don't laugh. They actually have pipe cleaners in them. They have swabs that have, long necked swabs in there. You see tweezers, et cetera, multiple trays. Basically, the last tray is for drying. So you start with gross cleaning and then you start with just getting the, a little bit the debris, a disinfection process in the middle tray. And then the last one would be primarily typically for air drying. This figure is just showing you one of the many available types of trach tube holders. This one is produced by Dale, D-A-L-E. And the nice thing is it's foam. It's relatively inexpensive. It can be readily adjusted, and the foam minimizes the chance of, if you will, the skin on the neck breaking down, as you can sometimes see when twill is used. When twill is used, this is almost like a shoelace type material that's used. It's okay to use for a few hours or maybe a day, but using it for too long can actually cause the skin to break down, and that's just not a good thing. So this is one of many products that's out there that can help prevent that potential complication. So this slide addresses the issue of speech or facilitating speech in the tracheostomized patient. Generally speaking, it can be accommodated with patients that are receiving mechanical ventilation. There are passe-mur valves that can be used on patients who are on ventilators. It's not common to do that, and they can be. It's a little complex in that sometimes those passe-murs can get filled with secretions, things along those lines. So most patients that have speaking valves in place and they have trachs are not currently on a ventilator. They're sometimes called talking tracheostomy tubes, cuffed down so that with a clean finger hand, the cuff can be deflated and the finger can occlude the the end of the if you will proximal end of the tracheostomy tube. Cuffed down with speaking valves is probably one of the most common methods, and one of them, the passe-mur valve is a one-way valve that allows air to go in through the tracheostomy tube, but does not allow it out, and would then permit that air to go up to the vocal cords and enable the patient to speak. This is just an image, if you will, showing you a few of the available models that are out there of speaking valves. And again, the basic design is one-way valve. Patient can breathe in through the tube, but when they breathe out, it does not allow air to come out through the tube. Rather, it goes up to the vocal cords so the patient can, as I said earlier, speak. Changing the tracheostomy tube, everything is straightforward if you know how to do it, but generally it's a relatively straightforward procedure once the stoma is well formed or well established. In the preceding slide, I said every 2 to 4 weeks, so about every 30 days or sooner if warranted. Sometimes what they'll do is they will change trach tubes in pediatric patients a bit more frequently, closer to that 2-week interval rather than 30-day interval. Requires trained personnel. First change. So once the tube is put in place, roughly 30 days later, they should have a trach tube change. Generally should be done by a trained physician. Many of the hospitals will say the first one really should be done because now that stoma has formed around it, and there may be, some of that tissue may have actually attached to the tube, so it may require a very minor, cutting and just minor surgical procedure to get it out. And then it really, most protocols call for having a trach tube one size smaller at the bedside. In case once that the existing tube is taken out, let's say it's an 8 for an adult, a new 8 won't go in. You'll have a 6 that you can actually put in there as well. When I did home care, I've changed trachs in the hospital, but I did home care. When I did home care, our protocol was to have one size smaller. So anytime we were taking a tracheostomized patient home, we always had, if they had an 8, we always automatically, they would have, with the initial equipment delivery, they would have a 6 as well. Person who is skilled in intubation really should be on standby. So in case the tube doesn't want to go in for whatever reason, and even a size smaller doesn't want to go in or has found a false track, we've had cases where in extreme circumstance where just to get an airway in place, where a 6 ET tube was put in through the stoma and temporarily, surgically, just a stitch or two attached until the airway could be, the trach could be reestablished and that trach tube put in place. A very important topic relates to responding to emergencies for patients that have tracheostomy tubes. One of those emergencies is an occluded trach tube, perhaps due to mucus plugging, where you can't ventilate the patient. So you should first attempt to pass a suction catheter and suction the patient. If the suction catheter will not pass, consider very carefully introducing a bougie. Okay, so bougie is actually a device that's used, a gum bougie, sometimes it's referred to, and some clinicians will use it as a means of, if you will, kind of a guide, not literally a guide wire, but a guide-like wire, so that it can be passed through the vocal cords and the ET tube threaded through it. Okay. Bougies can also be used to, if there's a mucus plug that will not come out, and you've tried all the obvious stuff, you can try to maybe pass a bougie through. Indeed, you will be taking that plug and pushing it down, but better that than not to have an established airway. Remove or changing the inner cannula is something else that should be strongly considered. Hence, there should be extra inner cannulas in the room. However, even without the inner cannula in place, you can just try to manage the patient effectively as well. But there should always be an extra inner cannula in this patient's room, because you cannot ventilate with most Shiley tracheostomy tubes. You cannot ventilate the patient if they're on mechanical ventilation. You can't attach that tubing unless there's an inner cannula in place. There are others, there's Portex tubes that are out there where the inner cannula doesn't actually have a flange on it. The flange is part of the tube itself. But Portex tubes are not commonly used. So in all cases, you really should consider strongly ensuring that there's extra inner cannulas in the bed at the bedside. Decannulation is the last resort, only if done if intubation personnel and equipment are at bedside. Prevention is the best, if you will, way of addressing this sort of an occlusion by providing adequate humidification, better aerosol, suctioning, maintenance of adequate hydration for the patient. So patients who are dehydrated will tend to have thicker secretions. So one way of helping manage thicker secretions is making sure that the patient is adequately hydrated. I could say more on that, but I'll stop there in the interest of time. Another area of concern is the potential for accidental decannulation, whether it's a patient deliberately pulling it out or the patient, unplanned decannulation where the patient was rolled to one side and the tubing pulled and their trach tube came out. And particularly troubling when the decannulation occurs before a mature tract is established. That can be potentially disastrous. Rapid airway closure can occur in an unestablished stoma. Blind reinsertion attempts are at risk of going into a false track, into a false passage. You're passing through 7 layers of tissue from the outer portion of the stoma until you get into the trachea. So false tracks are a risk. The best response, attempt to reinsert the same tube, providing it didn't go on the floor or something along those lines. You're not going to, tube falls on the floor, it needs to go in the garbage. But the tube that has just come out, it has natural lubricants on it. It has mucus on it. It's probably, it's going to sound strange, but it's probably warm, so it's more pliable. It can most readily be put back in. Attempt to reinsert one size smaller. Insert the appropriate endotracheal tube in an emergency just to get an airway in place, and obviously calling for help. You can cover the stoma and ventilate the patient via bag valve mask. Again, that's kind of, I don't want to say a last resort, but that would be an extreme measure. Other complications include tracheomalacia, which is softening of the tracheal wall, occurs prior to stenosis in many cases. Stenosis is really accounts for a significant amount of the complications of tracheostomy, where the tissue is no longer just soft, it's actually started to form, if you will, scar tissue. Tracheal esophageal fistula occurs in less than 1% of the patients that have a tracheostomy, so that's where you now have patency between the trachea and the esophagus, so it's just a recipe for ongoing aspiration. Tracheal arterial, tracheal inanimate, sometimes the inanimate artery fistula erosion is one of the most feared and lethal complications. So once that artery wall is eroded through, the patient can exsanguinate, so they will actually have massive bleeding into their airway, so they can bleed out and suffocate at the same time. Just a bad place to be. The only real hope for a patient like that is if you can get the cuff of the tube to where the erosion is and hold it there. You're not going to be able to see. You're going to have to do it by the bleeding will slow down immensely if you can do that, and then get the patient to the OR and just not moving that tube at all. But in all likelihood, the patient will pass away because of that. Now let's focus briefly on weaning prior to final removal. So increasing periods of cuff deflation and liberation from mechanical ventilation as well. You'd really want, as you're weaning, we're really not talking about mechanical ventilation weaning, we're talking about weaning them off of the tracheostomy tube, but one follows the other. So the patient hopefully has been successfully weaned off the ventilator, they've been off for a few days, so now we're really looking at periods where the cuff is deflated for longer and longer periods of time, change to a fenestrated tube, eventually hopefully change to a cuffless tube, combining that with speaking valves in order to build the patient up, their respiratory and speaking muscles. And then you're looking at downsizing the tracheostomy tube from an 8 to a 6 to a 4, and not literally cork, but capping the end of the tube. Different things along those lines. Get them down to a 4, get them hopefully decannulated in a safe and planned manner. The decision to decannulate is a collective decision, obviously driven by the patient and the physicians. Patient, if they tolerate plugging overnight, we're not talking about mucus plugging, we're talking about capping. While they're asleep, monitoring their O2 saturation if they don't have any issues with that. If they do have minor desaturations, provide them with some supplemental oxygen. Subsequently, tube is removed, the skin is, when I say taped shut, in some cases they are, in some cases just you have gauze, you have tape, and you just tape over the stoma and encourage the patient not to speak, and when they do speak, to put their hand over that gauze to try to minimize any air from escaping. And the wound will heal 5 to 7 days, 5 to 10 days, something along those lines. About 90% of them will heal within that time frame. Now we'll quickly look at some cases, and then we'll come down the home stretch here. In this case, we have a 54-year-old COPD patient has been intubated for 12 days, has failed successive spontaneous breathing trials. So really the theme of this one, what would you recommend? What we're going to recommend is that the patient be tracheostomized. So they would be tracheostomized for a few reasons. One of them is, the biggest one is that they've had this tube going through their vocal cords. And the longer the ET tube goes through the vocal cords, the more likely the chance that there'll be some sort of vocal cord pathology, some paralysis, some polyps that can form, some scarring around it, those sorts of things. So you minimize the likelihood of those sorts of problems happening. The second big reason is, as I alluded to very early in this presentation, the trach tube is about a third the length of an endotracheal tube. So patients will tend to wean much better with a trach tube in place than with an endotracheal tube. So this is just a continuation or a little bit more elaboration. It's not really a separate case as I've listed here, but why might the patient in the preceding slide, end up weaning better with the trach tube? And again, it has to do a lot with the fact that the tube is much, it's about a third of the length. It also has to do perhaps with the fact that the patient's state of mind, that they'll need less sedation. They'll be more alert. They perhaps can participate. You explain to them, listen, we're going to be turning down your pressure support. Pressure support is the boost that the ventilator gives you. They'll better be able to participate in the weaning process. So it has to do with the resistance that's imposed on the patient by the artificial airway, with less resistance being imposed by a trach tube versus an endotracheal tube. But it has to do with some other factors as well. And then what other advantages might the trach tube afford this patient? Things like eating, some of the, very, very important things like potentially, when they get weaned off or as they're on the verge of that, potentially speech being facilitated, particularly if we got to the point where they're only on the ventilator at night, perhaps during the day they can get a speaking valve in place. So there's really a whole lot of advantages. Mouth care can be much better facilitated with a trach tube versus an endotracheal tube. Many, many advantages to a trach versus an endotracheal tube. The patient in the preceding slide has an 8 DCT. So this is a little bit like Jeopardy for tracheostomy tubes. What does DCT stand for? And again, there was an early slide in this that basically talks to its disposable intercannula cuffed tracheostomy. So it's cuffed. By the way, DCT is one of the most common, by far, one of the most common endotracheal tubes that's actually used. Shiley uses these initials. When would the initial sutures be removed and by whom? Again, it would depend on a lot of variables, but typically no sooner than 2 to 3 days, as long as about 7 days. It's done with a collaboration with the physician who's actually managing the patient. Often it's done in an ICU or step down, and very good idea to get an order from the physician, a formal communication from the physician that it's okay to remove those sutures. And they're flange sutures. It can be done by us, it can be done by nursing. Sometimes the physician will want to actually do it themselves, is fine. But there's actually a suture removal kit is fine with a chuck there, and just great care, cleaning the site where the stitches have been removed and making sure that all the suture material has been removed. That's really, it could be a potential cause for infection, so of critical importance to do that. What sort of trach care would be done and how often would it be done? Trach care, as I said in one of the preceding slides, at least every 8 to 12 hours. It involves changing the intercannula if it's a disposable one, or doing intercannula cleaning, drain sponges, cleaning around the stoma, cleaning the actual tube itself, and often, though not always, changing the actual the tie that's holding the trach tube around the patient's neck. How often would trach care would the trach be changed if decannulation is not planned in the near term? About once a month. And again, there's a little bit of variation from that. It could be every 2 weeks, but typically around every month. So it's something when you have a trach patient, these are things that you should pay attention to And if it hasn't been changed for 6 weeks, it should be brought to people's attention. If the patient's getting transferred out, and let's say it's been 3 weeks, maybe it's a good idea. They're in an acute care hospital. They're going to a long-term care facility. Good idea. Maybe change it right there in the acute care hospital, so it would alter that interval when the clinical situation warrants it. Case 4, just like case 2 is a continuation of case 1, case 4 is a pseudo continuation of case 3. Same patient now has been on a T-piece, a trach collar for 36 hours, tolerating it quite well. What additional recommendations might you have for facilitating speech and eventual decannulation? So a few things, certainly the speaking valve. We've talked about that. We've talked about perhaps switching them to a fenestrated tube, downsizing them, maybe going from an 8 unfenestrated to a 6 fenestrated. 36 hours is a little bit questionable. Maybe you want to keep the cuff tube, stick with a cuff tube. But if that 36 hours was more like 3 days, 72 hours, something along those lines, and they've been off the ventilator, they're doing very well, then maybe the vent can be DC'd altogether, and the patient can be transitioned to a cuffless tube. So coming down the home stretch here, I'm just trying to take some of the key themes that we've gone over the past 45 or 50 minutes. The trach tube should be considered for patients intubated more than about 10 to 14 days, and where extubation is not imminent. Many types of trach tubes for different patients in different clinical situations. So many, and by the way, even more than I've gone over in this presentation, but again, for the sake of covering key points in a relatively limited period of time, we've really focused on some of the most common variations. Trach tubes and the patients that have them require care and maintenance. So, simply put, it's a hole in the patient's throat. The normal humidification and filtration that happens, that's done by the nose, is not done as well. So there's considerations there. You don't get something for nothing. The patient gets the ability to breathe. If they're weaning, they can maybe wean better, but devil's in the details, and it needs to be done right. And when in doubt, ask a respiratory therapist for help. So, a lot of the folks that are probably listening to this are respiratory therapists. But if you're a new grad or you just haven't worked around tracheostomy tubes and trachs very much, no problem in asking for help. If you're a nurse, and my wife's a nurse, so if you're a nurse and you want to learn more about this, good idea to, get a respiratory therapist or a pulmonologist involved, so you can make sure that you're completely up to snuff. Some references that may prove helpful to you are listed here. 2 of the 3 textbooks that I do include Egan's Fundamentals of Respiratory Care. I'm a co-editor along with Bob Kazmarek, who has fairly recently passed away, Dr. Jamie Stoller at the Cleveland Clinic, and myself. And there's actually a good chapter in there that talks all about airways. It does talk about endotracheal tubes as well. It talks about LMAs, but it also focuses on tracheostomy tubes. In addition, one of my other textbooks, Clinical Assessment in Respiratory Care, is just all about assessing the patient, assessing airways, and things along those lines. In addition, there's other guidelines and articles that are out there. Teresa Velasco and others have published a clinical practice guideline on the management of pediatric patients with tracheostomy tubes in an acute care setting. For the nurses that may be listening to or attending this, the AARC is the American Association for Respiratory Care. And we have clinical practice guidelines on many different interventions, both diagnostic and therapeutic. And this particular one, gives some excellent guidance on tracheostomy tubes, particularly in the pediatric population. And then there's the primary sources. You can go to, Hopkins Medicine has some outstanding materials that are online that can, help, both videos, static images, as well as guidelines and policies and procedures that can be used. The National Institutes of Health also has some, health topics series, and they have a particular one that really focuses on tracheostomy and tracheostomy tubes. With that, I want to thank you all for attending today's session and listening to this presentation. Terry and I hope that you really, you got something out of this. hopefully you can apply this information, whether it be new information to you or just reinforce things that you learned a while back and you just needed a little bit of reinforcement on. And I guess as important as anything, this presentation represents one of a whole bunch of presentations that we do as part of A&T lectures. So we hope that you come back to us and join us for other sessions. And again, we want to thank you very much for choosing A&T lectures. Thank you very much and have a wonderful day. Bye.